Hi, good afternoon, everybody. This is Louise from the Clinic Association of LA County. I see that we have a number of folks are already signed on and watching us from the webinar, so welcome to all of you. We anticipate we'll have a couple more joining as we continue on. Just a couple quick housekeeping notes before we kick off our kickoff of Financial Strength. Is that you do have a chat box through the GoToWebinar controls. If you have questions throughout the course of the webinar, please type them into the chat box and we will answer them throughout the course of the webinar. Because of the number of people on the webinar today, we are not unmuting folks' phones just because it ends up creating a little bit too much background noise and chaos. So please, if you've got questions throughout, pop them into the question box. Additionally, you'll see on the control panel for this that there is an attachments tab, and so you are able to actually see the attachments that we'll be referencing throughout this presentation as well. So with that, those are our housekeeping. AFS stands for Advancing Financial Strength, and today we are in the 101 intro course. This is a partnership that the Clinic Association has now, we're starting our third iteration of doing Financial Strength, and we've learned a lot from the last couple of years. But the goal here is really to help you as community clinics and community health centers understand where you are at with your finance and operations, understand how you compare to your colleagues here in LA as well as in other parts of the state and nation, and looking at the areas where you have room for improvement and helping you get the tools you need so that you can take those measures and move them. So really thinking about how are we going to affect cash on hand? How are we going to affect productivity? How are we going to affect the bottom line of the organization so that we can continue to meet our mission and expand upon that going forward? So to date, we've had around 38 plus organizations participate in some way, shape, or form through our Financial Strength cohorts. This year, we are launching this in not a cohort program. Instead, if you've been through any of these programs, we want to make sure that you continue to get access to the resources and that you're able to avail yourself. So it's not a cohort, it is an open access program. However, in as much as there's a 100, 200, and 300 series that we're offering, folks that are going to do the 200 series will have need to do the prerequisites first. If you did the prerequisites last year, cool, but if you want to do them again and you need some refreshers, cool. If you have additional staff that you'd like to bring on board that you want to make sure understands what's offered here, cool as well. This webinar that we're offering now, we are going to be offering a refresher in January, I want to say, to be able to just refresh if there's additional folks that you want to bring into what we're doing and understand all of these measures and the benchmarks. That's an opportunity going forward as well. Our partners with this, so LA Care Health Plan and Cedars-Sinai support this project and give us funding so that we are able to afford these services that we'll be providing you. And we leverage our partnership with Capital Link, who is really a key partner for community health centers across the nation. The Bureau of Primary Health Care has dubbed them as a cooperative agreement and really trusts them with data around operations and finance. So really leveraging local funders along with a national partner. So with that, I'm just really excited that you're all on the call today and getting ready to flex your financial strength and really work on your core. So with that, I'll hand it over to our team to get this kicked off, and we're really excited to have our colleagues from Capital Link, Jonathan Chapman and Susan Petrie, here with us today. And I believe we've unmuted you, Jonathan and Susan.
Okay, great. Thank you. This is Susan Petrie. I work at Capital Link. I'm the Chief Operating Officer. Thank you for the very nice introduction, Louise. It's been really terrific working with the Community Clinic Association of LA County over the last couple of years on this program and project, and it's helped informed a lot of our activities across the nation, and there's a lot of leveraging back and forth on lessons learned and best practices. So we really appreciate the opportunity to work with you folks and to work with CCALAC. So I will start and then turn over some more of the benchmarking and dashboards to Jonathan, and then I will wrap up at the end of our call. But as already mentioned, please do go ahead and type in your questions if you have them, so we can address them as you go along, and I will get started. So just a quick, a few more minutes on Capital Link, a couple more points, just so you know who we are. I know we've worked with a number of the health centers. I did get a list of the participants on this call, and it's great to see such a wide variety of health centers. It looked like almost 30 represented, which is really fantastic. I know most of you have been involved in the last year or two, but I saw a couple of new centers, so that's terrific as well. But just so you know who we are, we've been around for about 20 years. As Louise mentioned, we are a HRSA National Cooperative Agreement partner, and we're a nonprofit, and we actually have offices in 7 states. We're a fairly small organization, but we're national. And one of our largest states that we do the most business in is actually California, which makes a good deal of sense given the size of the state and the fact that about 10% of all health centers are located in California, as well as the tremendous amount of support that's given by foundations out here, and also just the progressive nature of the state. So it's really great to be working and doing so much business and helping, hopefully, health centers here in California pretty significantly. So we are also in Colorado, Massachusetts, Maine, Missouri, South Carolina, and West Virginia. We work in all 50 states, essentially. We've worked with about 45 of the PCAs. We work with, I think, about 90% of the consortia in California. Work very closely with CPCA and with many dozens of the health centers. So we're pretty familiar with a lot of your activities, and we have a good depth of experience in terms of the finances and the numbers and the metrics and the financial audits and so forth from California health centers as well as those across the nation. Talking about our history, just to give you a sense of, where are we getting this data and why and how should you trust it, we have done about over 225 capital projects, and we started by helping health centers get access to financing. And we've assisted in about $1.1 billion in financing projects over the last 20 years since inception. So as part of that process, we have gathered a lot of financial data. We have the financial audits for all of the national health centers, so for about, there's a little over 1,200 now. We have about 90% for the last year or two of all financial audits nationally. We have about 95% of California. We have all the UDF information, and we have all of that information for the last about 10 years. So we really have a lot of good data and tracking information. So, and we have data now through about 2016 audits. As you know, those are pretty much just wrapping up the 2017. Some of you have probably completed those, a lot have not. We're actually just wrapping up our own 2017 audit with the year ending June 30th, so we know that really the best information available right now is through 2016. So we have this information, and we've been looking at metrics and benchmarks and best practices, and we decided a couple of years ago to start using the information for reasons other than capital projects, because a lot of folks were asking about, what's a good number and what's a good range, and how do I know if I'm doing a good job, and what are some benchmarks, or what are my peers doing around the country and so forth. So a couple of years ago, we had spoken with Louise, who had the vision to understand the need to understand this data and this information, and to share it in a way that wasn't just considered kind of finance or just shared with the financial folks, like, oh, this is how our numbers are going, but more to understand what it all meant and how to use this information, gather the information, and use it in a way to help operations be more efficient and to help increase access to care and improve readiness for growth. So if you want to move ahead to the next page, please, Kaylee, I will just summarize, how this program came about. As Louise mentioned, it's been around. This is the third year. It was initially envisioned as a one-year program, developed with CCALAC with tools and training and technical assistance. It's been so successful that we're now in the third year with a lot of great foundation support from LA Care as well as Cedars-Sinai. And a founding partner was Blue Shield of California Foundation, who's been doing a lot of work with Capital Link on the data side for a number of years and has been really supportive in getting this off the ground to, across the state. But in your particular region in LA, there's been a lot of support by those two regional foundations, which has been very helpful. And the idea is that it's not a CFO training program, but more of an integrated learning experience where it's not like a one-off, go to a conference, the CFOs learn about XYZ or something like that. It's more intended to be people from all walks of life in the organization, so CEOs, COOs, finance people, clinical staff, board members, and really getting everybody kind of on the same page. So that's really what's intended here, and also to have multiple approaches so that it's not just a one-off, but there's tools, there's reports, there's training, and so forth. So moving to the next page, the overall goal is financial sustainability and access to high-quality care. So I do want to just emphasize, and I'm not going to mention it through every slide, and I know that Jonathan will not either, but basically we all have the same goal in terms of, staying open, doing a great job so we can provide access to high-quality care for the people that need it. And the idea is that it's all interconnected, and if we can't operate efficiently and pay the bills and have cash flow, we're not going to be able to keep the doors open. So when you hear us talking about finances or efficiencies or productivity, please understand that it's within that context of providing really good care, and that we're not going to mention that every time, but that's certainly the undergirding principle is that we want that access and excellent results. So the thought is that everything's interconnected, the financial operations, staffing, productivity, utilization, outcomes, patient satisfaction, that they're all working well together and the team is communicating effectively, that's going to make for more effective and efficient operations and improved access to care and keeping the doors open, essentially, and allowing for growth, hopefully. So moving on to the key components of advancing financial strength on an overall basis. Since we're kicking off today, we are talking about the 101 series, which is one component under the 100 series. And basically it's to understand, to look at assessments and do some training on metrics and benchmarking to improve efficiencies. So that's the bulk of today's session. But we did want to just give you a quick overview on some of the other things that are happening and how it all fits into the total program. As I mentioned, this program was developed with CCALAC, but a big part of it has been, it's basically been put together by health centers for health centers, so that you folks and your peers and colleagues that were in the prior sessions as well have really helped us decide what's most important. And with CCALAC's guidance, we put together customized programs for you. Many of the trainings and learnings and a lot of what we'll go through today are important concepts and ideas to know anyway. But as we continue further, we're doing more advanced training and more advanced programs. And as the market changes and the demand and need for information and the types of information change, we're continuing to evolve. So it's not exactly the same program that we did a couple of years ago, but a lot of the concepts, as I said, that you'll learn today are really important to continue to look at and to develop and evolve over time. So the first part is understanding. The second is developing action plans. And the third is implementing and monitoring those plans. So the assessment includes both performance evaluation and profiles, which is a comparative peer benchmarking analysis, looking at your own health center's performance over time on about 70 key metrics, financial and operational, and comparing it to CCALAC, California overall, and national. The second part, and as well as some training that we are starting today to help you understand what it means and what to really focus on. The second is developing action plans, so looking at the findings of those programs and assessments and training and tools to determine how to move forward. So we know we have a revenue cycle management problem. Our metrics are much weaker than everybody else. There really isn't a good explanation for it that we understand. We want to understand what's going on here and see if there's room for improvement, and how do we go about doing that. And then the third is implementing and monitoring those changes and those ideas that you put forward. All of this is an ongoing process, so it's not as if one does the assessment once and then is done with it. I know you all internally are checking your performance on key measures. We have helped CCALAC implement some ongoing measurements in the CFO network and other networks, so that on a monthly basis or quarterly basis, people can share with their peers and so forth. We do these assessment reports once a year because it's a fairly significant undertaking. But all of this is a process and ongoing training. Talking a little bit about what we've accomplished since we started over the last couple of years. We're going into the third year. About 40 health centers have participated to date. Several hundred, about 500 different people have come to one or more AFS training programs. Many came to 5 or more. Some came to 10 or more, those that have been involved for a couple of years. And we really encourage you to come regularly, bring your peers. One of the biggest bonuses or benefits of this program is sharing with other staff. Sometimes it's CFOs. If you're a CFO, you might be sharing with CFOs or CLOs and CMOs and revenue cycle managers and clinical staff are all sharing with each other, and the peer learning is really helpful. We've also produced about 100 performance evaluation profiles for CCALAC in the individual centers. We anticipate producing another 50 or more this year for the individual centers and the consortium overall. And importantly, over 25 health centers have received hands-on individualized technical assistance and coaching. And that's part of the 300 series, which comes a little bit later in the process and in the program. And with that, it's support from the foundation for individual help. So once an idea is, or once an area for improvement is identified, then up to 40 hours of assistance is given for individualized training and specialized programming and on-site development. And so that's been extremely helpful. I know a couple people on the phone, or at least the health centers on the phone, have been involved in that. We've heard very good feedback. And that type of support can range from anything from change management to process improvements to revenue cycle management, to financial forecasting, so whatever you might need. So definitely, as we move along in the program, keep that in mind, because that is something that will be made available again this year. I believe that the people with that will have the most access will be those that have not received the individual financing in the past or the support in the past for that program, but there may be additional funds. So more will be coming from CCALAC on that, but that would be kind of the final stage of the program. Moving ahead to the next slide, some of what we've accomplished is, as I mentioned, that benchmarking and tracking and decision-making being used across the consortium. People are operating with much more strategic agility with scenario planning, financial modeling, planning for difficult times, how you operate when things are so uncertain. We've done a lot of programs on that. We'll continue to do that in the coming year. Increasing access through new scheduling models, revenue cycle management. So there's been some specific small group training programs, larger programs. We anticipate doing all of that again this year. Some of it will be the same as last year. Some of it will be advanced. So if you came to some programs last year or your peers did, they may find the advanced program more helpful. If you've not been involved in the past, then you might want to do some of the more basic programs. So hopefully there's something for everyone. We also, on the next page, have done some strategic and data-driven market analysis, basically helping people understand what to do with this data in order for them to make effective decisions, and what does it mean. Facility planning, we worked with LA Christian, Harbor Community Clinic, and some of your other peers in terms of some of their strategic facility development, capital financing plans, making sure they're using the most, making the best use of their space. We've done financial forecasts and business plans, and also looked at some cost-effective financing structures. And going to the next page, just, wrapping up some of the other accomplishments and what we want to see continue with this new round of funding and programming and training, as well as continue to do even more, is the boost in team-based care effectiveness, upgraded leadership skills, organizational changes, and bottom line, is stronger financial results and sustainability. When Jonathan goes through some of the slides in a couple of minutes, you will see the vast improvements at CCALAC over the last couple of years. We know some of that is attributable to the increase in Medicaid. The Medicaid expansion for sure has certainly helped, but the improvement in terms of productivity and some of the other measures on revenue cycle management and the amount of days cash on hand and some other measures are certainly due to the commitment of the people that have been involved in this program to really improve their operations. And so it's exciting to be able to quantify some of those results, and hopefully we'll continue to see really good success in that area. I do want to just go through the preliminary schedule for AFS 3 program. I do want to point out that today is a kickoff webinar, and in order to have performance evaluation profiles done for your organizations, we need the 2016 audit information if we do not already have it. I know Lisa and the team have reached out to you. We have almost all of the information. There's just a few missing audits, and so please send that along to them. Our absolute cutoff for the missing data is October 10th, so that's Tuesday. And if we don't have it by then we really can't run a performance evaluation profile for you, so you won't get what Jonathan is going to be showing today in terms of comparing your performance over time on these key metrics versus peers and benchmarks. So that's an important date to keep in mind. So we will be sending out those reports to CCALAC to share with the individual health centers by November 2nd. And a week later, we will be doing an in-person AFS launch with one-on-one meetings with Capital Link staff to go through any findings or questions you may have on the performance evaluation profiles, or PEPs. I apologize, it seems like we're getting a little feedback. I'm not sure where that's coming from. So we look forward to meeting with you then. Jonathan and I will both be there, perhaps one or two other Capital Link staffers. You will, when you get the PEP, it will have an analysis of strengths and weaknesses and areas that you may want to focus on, but we will also be there to review it in more detail and answer any questions you have at that time. December 8th, there'll be workshops on productivity and revenue cycle management improvements. And in December, as I mentioned, there'll be grant applications due for specific health center technical assistance with some funds that are being made available by the foundations. Then for March 2018, it's basically a 1.5 or 1.5 or 2 day in-person training event. It has plenary sessions, small group training programs, breakouts, wonderful opportunities. It's been very well attended the last couple of years. We usually have between 75 and 85 people from all different disciplines, sharing best practices, meeting on everything ranging from productivity to change management to predictive analytics to strategic planning. And that will very much be determined in coordination with you. CCALAC is great about getting feedback from the participants and their members in terms of what they would find most useful. So we very much will develop the program or continue to upgrade and enhance the program based on what you find most important now. Those core concepts will continue to be a big part of the program, but anything that's really kind of driving your decision-making or making things difficult or anything we can do to help guide that, we're happy to develop expertise and bring programs in for you guys to do that. And then also through calendar 2018, there'll be all sorts of small group training programs on some of these topics. Cost of care has become very hot right now. It's extremely important for health centers to understand their cost of care and how they compare to others in particular measures. That's a new area for us that we're really digging into, looking at UDS statistics and cost of care by category. So stay tuned for that. I think people will find that very interesting. And a lot of the ideas that I've talked about previously. And we'll also, during during calendar 2018, be doing ongoing individual health center coaching, technical assistance, and support. So anyway, that's just a brief overview of the program itself. And now I am going to turn it over to Jonathan, who will do the 101 specific training. Thank you.
Good afternoon. Thanks, Susan, and thanks, Louise, for having us and continuing this collaboration. As they mentioned a couple of times, this isn't the first year. I think from the registration list, we've got several folks that we've worked with in the past. And so you know that we've been able to establish quite a few benchmarks and a robust database around the Los Angeles area health centers. So we're happy to present some of the more updated numbers and recent trends that we're seeing now. So what does success look like? You know, we talk a lot about, you know, the aspect of a successful health center or a high performer. And we find here that, you know, introducing the data, you can't manage what you don't know, and you can't know what you don't measure. So we've got here, very familiar to some of you, the wisdom triangle. And so as you put together a lot of your reports, and I'm sure most, if not all of you, are inundated with various data and sources and information, a lot of that comes to you. Unless it's understandable and you're able to implement it in your decision-making process, it's just mere data. You're looking at sheets of numbers and letters. It really doesn't influence how you operate your health center. And so what we try to do is work our way up through this pyramid, throughout the AFS process, throughout the, you know, the assistance process in general. And then once it becomes information, it's somewhat useful, organized, and structured. And I like to compare that to like the UDS. Very standardized across the board. A lot of folks understand it, and I understand that there's always some fluctuation in how things are reported, and because it's self-reported. And I know that there's quite a bit of effort going forward in making that data better and also more immediate. So that is something that we just recognize now as kind of a date stamp, a look in the past, a little bit like some of the information we'll look at today. But as we go forward, we try to transform that into knowledge, something that you understand where the numbers come from, you understand the aspect, the context, and then being able to take that and putting it into a data-driven decision process where you can sit at the top and feel so much wiser, knowing that the consequences of your decisions, the best and worst case scenarios. We mentioned scenario planning earlier on. You know, you're able to take, you know, relatively small amount of your operational data and see how small changes can certainly have a ripple effect through the organization. Move on. So some of the benchmarking and best practices, you know, when we start talking about establishing those metrics, and I'm sure that again, most, if not all of you, have favorite metrics, if you will. You know, those handful of metrics that you look at every year, every month, every day, some of you. The number of patients, operating margins, am I successful? Am I financially secure? Working with health centers with multiple sites that try to get that down to a site level so they can make staffing and reinvestment decisions. But here we start to look at what do you want to track? Whether it be financial or clinical or just some other operational, perhaps patient satisfaction. And where would you find this data? You know, we talk a lot about the various different resources, and you know, we'll mention the UDS and the financial audits and OSPED and things of that nature. Again, very standardized amount of data. You know, there's a lot more resources out there. You know, we get those questions quite frequently about comparing community health centers with the private providers and what kind of numbers are there, and we're always striving for better comparison and apples there. So knowing where that data comes from and the methodology behind those comparison and reports are really important. And then trying to determine which metrics do you need. Well, really that's up to the organization. Again, you've got some that everybody seems to have in common, whether it's operating margin or you simply bringing in more money than you're spending. That's a pretty easy one. That's almost very similar, I would imagine, to personal accounting, if you will. You want to know if it's a patient trend. Are you seeing more patients than last year? Can you drill down and see the patients by provider, patients by service? You know, if your visits are going up year after year, but medical has kind of plateaued, then you're going to see a smaller percentage of medical visits. And what does that mean behind it? And that kind of transitions in how do you analyze it? Again, having some understanding of where the data comes from, even how it's collected. It's, you know, is it self-reported? Is there someone specific accountable? Is it regularly maintained and verified? And then who needs to know? Well, yeah, I think we're in a safe room here. We're all friends. So we'll be sharing some CCALAC specific data with your own organization. Certainly the financial and the clinical leadership want to know those metrics that are apply to them and their decisions and their operations, maybe even tied to incentives. You know, we'll talk a little bit about the transition from fee-for-service to value-based care, and the way incentives are certainly applied really does drive our behavior. So board members may want to know some of the basics as well. Certainly, a lot of the CFOs we talk to have a dashboard prepared, and we'll look at some samples of like dashboards from our PEP reports and things like that going forward. So all of these kind of conversations kind of overlap as you go through this process, and certainly as you make those internal decisions. Next slide. And here we've got, you know, I mentioned a little bit of the dashboards. You know, dashboards should be customized, and I'm not going to sit here and just read this, but certainly appropriate to your target audience. Is it the board? Is it staff? Is it just providers? Is it blinded, or do you have names, or is it by department? You certainly, again, want to choose those financial and operational metrics. Find those that have the most impact, easiest to trace, measure, and convey. You know, we don't want to track all 157 financial ratios that are possible because a lot of those duplicate some of those services and overlap. So again, find those that people tend to be able to understand quicker. And then match those reporting objectives with your available data sources. Very similar to what we mentioned, where is your data coming from? You know, every time we work with a group and it's like, so what are we going to track? They're like, please just pick something we're already tracking. You know, you can enhance it, you can change it, you can aggregate it, but please don't create a new metric, a new trend. And so I know that a lot of different payers have their favorite metrics, and then HRSA has theirs. You know, UDS versus HEDIS, financial audit, nonprofit versus healthcare kind of format and structure. So there's always some considerations, and you just need to make those decisions that best for your organization and your decision makers. And then explore those available reporting tools. How are you communicating this? Is it a lot of graphs on a piece of paper? I know, and this kind of dates me right here, but you know, if the font's too small, I have to reach for glasses. So maybe somebody will throw a presentation up when I'm in Los Angeles just to test that. But, you know, you can start with something as simple as Excel or find something that's more maybe cost effective or less of a learning curve and more turnkey operational. But it really does matter, you know, how you convey. You don't want to go through all this work to have folks not understanding the message or the motivation or the intentions behind your data. Next. And so right here, it's just for your awareness. We do have a benchmarking toolkit that you can get off of our resource and publications page on our website. Some of the information here is taken directly from that toolkit. So again, just another resource throughout your process. We mentioned determining some of the key metrics. Here are some of the ones that I guess are favorites in some of the Capital Link presentations. I know they're consistent. We mentioned the operating margin. Again, the margins in healthcare generally tend to be somewhat small. We try to look for a health center margin of 1% to 3%. We've worked with some hospitals that are very similar. We have some good news to share today. That a lot of those margins have been exceeded by the Los Angeles Health Center. So this is an easy presentation when I'm passing along good news. And then bottom line margin, it's very similar to operating margin, but includes capital-based grants and resources. You know, when HRSA has a lot of the capital grants, whether it's the HIP, SIP, those type of programs, you'll see the bottom line margin kind of bump up through capital projects. And then we have personnel related expense. Again, this is the highest expense in pretty much any service organization, especially community health centers. And through some determinations and benchmarks, it looks like between 70 and 75 is kind of the sweet spot. And again, we'll be able to compare that in just a few moments. Days and net patient AR, how fast are you turning your service into revenue? Days cash on hand. Typically, if your accounts receivables being turned over quicker, you have more cash on hand to be able to invest and take care of the day-to-day operations. So we certainly want to see that trend continue to increase. And then we've got some productivity. And this is good because we've established trends and benchmarks, but there's really a lack of a specific number that you try to shoot for. Again, it depends on how your providers are scheduling, what type of providers you have, how they're incentivized, what your operational needs might be. But again, it's good to know where you've been and be able to compare yourself to national or state trends. Next. And so here is our first data, finally. I've been talking about data. We'll actually look at some. So here's the operating margin over the last 4 years. And here we've got CCALAC, the median. And I'd like to stress that we do use medians to kind of offset the effects of outliers. And so here, any median, you can assume safely that half the health centers in that group are above that level and half of them are below. Now, we don't, in these slides, offer that extreme, but as we go through the AFS program, we'll look at all these numbers in more depth. And you may see some slight variation as we continue to collect those last few audits. But here you can see back in 2013, if we were looking for that 1 to 3%, it seems that, both the Los Angeles area, the California's state, as well as the national median, were all within safe. Now, there is quite a variance between 1.1 and 3.2. So you were exceeding both the state and national levels. And as we go forward in 2014, you can see that the state did improve significantly to kind of be the highest margin of this group. But what you really want to look at here is just the overall trend. You can see even national that falls below California and Los Angeles, the trend continues to be up. And I'm not going to dismiss the fact of Medicaid expansion by any means. We know that a lot of uninsured patients were either able to enroll in Medicaid or those, that were eligible and appropriate join the marketplace. So as we go forward, we'll look at the different payer mixes over time and find some similarities and certainly some porting numbers. But again, here you can see that the trends continue to be good and going upward, and in fact, doubling what we consider the benchmark. Next slide. And here's days cash on hand. So here's how much money do you have in the bank. So again, we have the the benchmark minimum of about 45 days. And there's been some discussion about that. And certainly, with some of the natural disasters that we've experienced across the country, health centers have had to close their doors for several days or even weeks. And so having that cash on hand enables them to maintain some level of operation. I've worked with some health centers that had to make that decision whether or not to pay employees during this time. And those that were able to pay their employees certainly were able to open their doors much sooner, build back up to capacity sooner. For those, staff as well as patients that are affected by things outside our control, certainly you want to have some sort of, cushion, if you will, and certainly have the opportunity to consider, certain offers, opportunities that go along with the managed care transition, just a lot of different things. And certainly, again, it's very similar to personal. And you can see here that all 3 medians were below that benchmark starting in 2012. And again, that trend has gone up again, I believe in correlation with the Medicaid expansion. And certainly just I believe that the emphasis on reimbursement transition has a lot of folks already doing cost control and looking how their reimbursements are, the diversification of revenues. So health centers have been hearing, you need to have a comfortable amount of cash on hand for any transition, whether it be an EMR implementation or a capital project or a reimbursement transition. And we can see here that, everyone, the trend continues up. Now in the Los Angeles area specifically, there was that little dip in 2015, but I just consider that pretty much a plateau from 12 to 15, and then a significant jump in 16. So good news all around. And just to add a personal note, I was giving this presentation to a group, another group in California, and the question came up is, well, if we are used to 20, 25 days cash on hand, and now I'm sitting on 100, am I in trouble? By no means are you in trouble. I think 100 days cash on hand is appropriate. And just because it's more than you've experienced in the past doesn't mean that it's too much or that it would raise a red flag. And in fact, in healthcare and a lot of industries, 100 days cash on hand is just the beginning. So again, these are the medians. Thank you. Next. And here's where we talked about the personnel related expenses being that highest cost driver. You can see here that all the national, state, and local medians have kind of followed along to that 70 to 75 benchmark. And here we've got the max, and you can see here that the max here is stated at 70. And so just, it's steady, it's plateaued, it's in a reasonable range. If you're much higher than 75, you really have to determine, the payment of staff. Have you lost patients? What is your reimbursement scheme, or, your PPS, things of that nature, and why that cost is so high. And it does limit your operations and opportunities. If that ratio was much lower, you would really, you may have a problem with, staff retention, provider retention. You may not be paying staff enough, or you may just be experience a surge in paying patients. And so you may have be able to build those cash reserves while this number is low, but this probably is not a number that you can continually have that low. Next. And then here we talk about the days and net pay receivables, about how fast you can turn that service into a reimbursable. Here you can see the benchmark max is approximately 60. And, again, we have, for the most part, these not a flat level, but a consistent trend across the board. You can see a little bit of dip in 2016 for both the state and the nation, while there was a little uptick in the Los Angeles area, although it's not much higher than it has been in the past. So it's not reason for a tremendous amount of concern, but there just may be simply circumstances in the Los Angeles area that others are not experiencing around wrap payments, turnaround, billing and coding issues. So a lot of this, again, will be further addressed when we have the on-site training with the group R individuals. Okay. And then we've got, shifting a little bit, we've got patients per payer as a percent of total patients. So, I find this graph very interesting when I talked about the expansion of Medicaid or Medi-Cal. Here, as a percent of total patients, you can see in 2013, they were exactly balanced, or the median was exactly balanced. And immediately in 2014, as Medicaid is expanded, the efforts for outreach and enrollment, you can see that the Medicaid enrollment, a positive trend up, mirror image, self-pay and uninsured going down. So this is something that we had hoped, had expected to see. And so again, it's nice to see such a continuing pattern with that. But it also means that we're relying on Medicaid a little more. As this slide, yeah, that was great. Perfect transition. As the collections of the patients. So if you go to the next slide, you can see the reliance on Medicaid here. Even with the growth of Medicaid, it's still a percent. Sorry, my computer just went to sleep. A percent of Medicaid is much higher than uninsured. Granted, they are a much better payer. Sorry, I'm having some technical difficulties. My screen just went blank. I'm assuming it's me.
It still looks good on our end, Jonathan, and we can hear you.
Okay. All right. Well, let's see if it's still. Yeah, I'm still here. All right, great. Sorry about that. It just simply went to sleep and took its time waking up. Hopefully the audience isn't taking power naps during this. But moving forward, again, the reliance on Medicaid has been pretty significant and steady over time. Okay, so now we come to the median growth rates, and this is the number of patients, not just patients, by payer mix, but a total number. So here we can see that, the Los Angeles area, it's always been positive for all the medians. You can see here that positive trend going up for national median, pretty consistent as Medicaid expands, health centers create and complete their capital projects and outreach, and the number of health centers grow. Here we've got, in the Los Angeles area, there was a significant growth in patients in 13 and a little bit of downward trend in 14 and 15, but a tremendous outreach again in 2016. A 12% growth in patients is tremendous. And so again, this is the median. So you've got half your health centers that are doing even better than this. So again, this is a very positive sign and certainly reflects the outreach of the health centers in the association. Next. And so when we start comparing patients and visits, I know right now, and again, we'll talk a little bit about the reimbursement transition, but while you grow in patients, you certainly want to keep an eye on the growth in visits. And here you'll see that the growth in visits is very close to the growth in patients. The more patients, the more visits, which is appropriate, again, in the fee-for-service and most of our reimbursement and quite frankly, our patient care, the way it's modeled currently. Again, you've got that nice, consistent national and state trend over the last couple of years and a tremendous growth in the Los Angeles median. And you'll remember here that the patients, they went down as well in 14, 15, but here we can see that the visits increased, which again, in a value-based care, you want to see the same number, if not more patients, but have different types of engagements or encounters with those patients. So just something to be aware of as we go forward and have those conversations. Next slide. Here is the physician visits per physician FTE. Straight off the UDS, looking at the medical doctors and the medical visits. And you can see here that there has been a pretty much a consistent downward trend in both the California state and the national medians. I see that across the country. I was pleasantly surprised, nothing wrong with that, in 2016 that your trend in Los Angeles took a kind of reverse. Over time and over different areas, we're seeing that, physician responsibilities and the complexity of patients, all the other administrative responsibilities that physicians do take on now, that they are seeing less visits per FTE per year. And so it will be interesting to get back into the operations and see where this number is coming from. Certainly, it's an encouraging trend. You certainly want your providers to be more efficient. And it's, again, it seems that you may be bucking the rest of the trends, which is positive. And I think the next slide continues with there it is, mid-levels. So we had talked a lot as the physician trend started to going down a couple of years ago about the mid-levels coming up. And there was, a great amount of appropriate discussion about mid-levels, kind of helping with the physician shortage and providing those other services. Here, again, you can see that the trend is kind of plateaued for the national and state. Again, in the Los Angeles area, significant increase, even more so than the physicians. So you can see here that the mid-levels are being much more efficient in the last year than that previous trend kind of reflected. Again, good news. So, it was great working with Louise and her staff, and they made the suggestion that we kind of look at some different ways of carving the Los Angeles Health Center numbers up. And so what we're going to present here is some CCALAC peer comparison that kind of looks at other metro areas, things of that nature. So the next slide, please. So we're going to look at just some creative ways of looking at this. So the peer comparison here, we've got the CCALAC median and then we've got the California median. I'm pretty sure that the green there is the Metro, California Metro median. So what we've got here is, again, very consistent, that peer comparison, related expense, looking at that 70 to 75. And here you can see in 2015, you trended down, which is a positive trend in this case, but it allows you to compare, you know, the medians within the city to the state. Next slide, please. So here, again, is the operating margin, and you've got the CCALAC median, the California Metro, which, again, I thought was a great idea of not just lumping all of California's health centers into a state number and having that as the comparison mark, but looking at those in San Francisco, Los Angeles, San Diego, to have a little bit more similarities in their operations. And you can see here that the operating margin in Los Angeles is a little bit lower than some of the other metro and state. But you can see here in 2016, again, a significant increase that would exceed both of those. And simply, we have not yet calculated all the 16 numbers. That's part of the AFS, so stay tuned for some of that coming up. Next slide, please. So here we've got, you know, days cash on hand and days in patient receivables, and certainly they do go hand in hand. You can see here that the days cash on hand is a little bit lower than the metro and the state number in days cash on hand. When compared to the patient receivables, you know, the Los Angeles median is a little bit higher. So that little delay that we talked about, around between 54 and 60 days that Los Angeles has traditionally, may be a direct relation in how much days cash you're able to maintain. You know, if the other metro areas are able to turn those services into cash quicker, they're able to accumulate that, which is reflected again in the days cash on hand, which in this case is close to 100. The note at the bottom certainly says that in 2016, your days cash on hand increased by almost 50%. But at the same time, days in patient receivables also grew. So again, that's one of those, I'd like to know a little bit where that came from. And so, you know, we certainly want to look at those medians and then those ranges, which again, we will have on hand on the on-site presentation. Next slide, please. Here's a really interesting slide that I wanted to make sure that we conveyed. So here we've got, you know, the California state median at the top, the metro in the middle, and then the Los Angeles area at the bottom. Looking at the dependency of Medi-Cal patients as total patients, comparing that with the uninsured and other. So you've got here, you know, at the top, the Medi-Cal 61 for the state, whereas in the Los Angeles area it's 65. You know, it's the uninsured patients are up to 28. So you've got a little bit more Medicaid, you've got a little bit more uninsured, obviously a little less private and Medicare, whereas the metro area kind of serves as that in between. It seems that they've kind of balanced those extremes between the state and the Los Angeles median. You can see here in the 2016, the uninsured, as we mentioned, fell again, as well as the Medi-Cal increasing. So again, these trends continue, and it's good to have, you know, again, apples to apples with other metro areas. Next slide. And here we've got just the growth of medical and dental visits. Now, again, this isn't an aggregate number of visits, it's a percentage. So if your organization just added, you know, an entirely new dental expansion, you may see an increase in the percent of dental visits and patients, while your medical or behavioral health may look like it's going down. You may have the same number of visits, it's just a smaller percentage. So, but in this case here, again, comparing Los Angeles Metro and the state, we can see here, you know, the Metro, the dental grew significantly, somewhat similar to the state, whereas the Los Angeles, again, you're seeing more medical visits than dental or likely behavioral health. And then in 2016, you've got here that both rose, 78% in medical and dental increased to 9%. Chances are, you know, if based on a pie, there's only so many percentage points to go around. we'd need to look at the behavioral health and enabling services and things of that nature. Next slide. So here we've got that productivity, and where I said that, you kind of went against these trends this past year. And here again, you can see that the physician visits per physician for the metro, I'm assuming that's state, as well as the blue is for the Los Angeles area. Here we've got, physician visits, mid-levels, and dental per FTE. And just looking at what that comparison is and that trend. Again, your productivity is better than both the state and the other metro areas, except in dental. Here it looks like, it's just over 100 visits per FTE. And so, in this case, it looks like it may be more significant than it really is. You're probably very close, depending on operational structures and things of that nature. But again, the mid-level visit, significantly higher than your metro counterparts. Next slide. So how does your health center compare? So now once you can continue to go to the next slide. So what we've got is the performance evaluation profile that we do try to run for each participating health center. And it provides a lot of the same comparisons that you just saw, but instead of a median across the board, it's your health center compared to some of those state and CCALAC medians. So it's much more personal. Probably you understand, the comparisons, differences, and similarities much more than just a bunch of medians. So I think we have a couple of screenshots from, So here we've got those peer comparisons. And for those of you that have participated in the past, you'll see that we took a lot of health center and client feedback and redesigned this. I am a fan of the new redesign. I think it provides pretty much the same type of information, but much easier visually to kind of pick out what you're looking for and to kind of convey it to others as well as comprehend it. So here, you can see at the top, the blue is XYZ. That would be the individual health center. And in this case, we have a state and national median. And again, we've worked with Louise and her team in finding the most appropriate comparisons for the upcoming tests. But you can see here the same type of graphs. It provides some of the actual data down below. So if you're a visual person or if you need the exact number, we have both that are pretty much on hand. So again, you've got patients on this page. Go to the next slide. Here's the financial dashboard. Again, very similar outlook, our structure, our design. Again, with the benchmarks and the health center's performance, along with any comparisons that are found appropriate. And again, these are the 5 that we tend to track the most often. Next slide. Here's your productivity dashboard where we look at those visits per FTEs. This is pretty much standard. Again, being able to trend your own organization over time and then compare that with either state, national, or other metro areas. But again, seeing those trends tend to go down and then the recent bump up. Again, I think it's good to have this context to be able to explain some of the variations over time, or to just ask good questions of your team over time. Here's you've got operations and utilization, where we kind of combine some of the support staff with operating revenue and expenses per patient. Certainly, let's see, you've got the graph on the bottom right or the middle right, where you look at the visit and patient growth, and you certainly want those to go hand in hand. And then you've got operating revenue and expense per visit at the upper right. You certainly want to make sure that your revenue exceeds your expense per visit, per patient. And so we've actually seen several organizations, where you see that trend kind of lower at 13 and 14, having that reversed. They were actually losing money for every patient or every visit. And fortunately and optimistically have seen a lot of those trends reverse. Next. And then here we've got the payer mix. To where you can keep over time a look at that payer mix and actually visually see the increase in Medicaid enrollment, and then some, depending on outreach and efforts, see the increases in Medicare, as well as private pay. So it is good to have all of those in one place and be able to kind of weigh those percentages over time. Next slide. So all of this, why are we doing all this, right? So everything changes. So we're certainly involved in, business models evolving over time, with the healthcare system being the economic driver yet burden that it is. A lot of folks being outpriced from the healthcare industry. We, looking at some of the transitions, whether it be the Affordable Care Act or a private payer wanting to do a value-based reimbursement, cost sharing. We've got IPAs across the country negotiating managed care contracts. So we know that our business model is changing, and it's enabled by the amount of data that we're able to collect and track and respond to. And certainly it makes our decisions and our negotiations better going forward. So just to touch on some of these business models and why we're going through the AFS and trying to work our way up that wisdom triangle. Next slide, please. So I've always liked to equate the transition from fee-for-service to a value-based reimbursement, kind of like a trapeze artist, right? You're high above. It's a dangerous hobby, if you will. Sometimes it's exhilarating, but you've kind of gotten comfortable with the trapeze you're on. And at some point, as you swing out, you're going to have to let go and grab the next one. And that's kind of what we're experiencing now. We've got some folks that are anxious to let go, and others that are hanging on until they can grab onto both rungs. And that may or may not be possible depending on the payers you operate with or the state that you're located in. So this is just a good visual to build your anxiety, if nothing else. Next slide. So here, when we talk about that decision, you can see here on the left where it looks at the revenue mix. You can see fee-for-service toward the top and the value-based reimbursement toward the bottom. And then in the middle, which I think we're entering, and then some folks are certainly in the cusp of that, this revenue transition period where we're not really sure how fast the transition is going to happen, how serious the transition is going to happen, how much risk we're going to have to take on in the transaction. So again, knowing what these cost elements are, knowing your productivity, certainly having some cash on hand in case of a rainy day. When we implement new programs, new pilots, there's always some little, hiccup in payment reimbursements, whether it be, the billing, wholesale, revenue reimbursement, things of that nature. But we do know going forward that as we come out of that transition period, that the reimbursement schemes are going to be flipped. You're certainly going to be more aware and more dependent on a value-based reimbursement. And hopefully we're all operating efficiently to where we can take advantage of that and continue our current growth. Whereas fee-for-service, we'll talk a little bit about incentives. That tends to go down. It'll be considered a misplaced incentive in some arenas. Next slide. And so here's some of the specifics. When you look from fee-for-service going over to value-based, volume to outcomes, individual health to population. The one I like is quality is a concern. Fee-for-service, we want our patients to get better, but that's not the driving financial force. Whereas in a value-based reimbursement, that quality is the financial driver. In a fee-for-service, standalone systems can thrive. Patient in, patient out, you bill for it, self-contained system. Whereas a value-based reimbursement, collaboration with other providers and other specialists is essential to make sure that your patients stay well. And you're having awareness of that health and those indicators, not only when they're inside your four walls, but while they're out living their life. Little financial risk, you kind of understand the current fee-for-service model, whereas there will be an increased financial risk. And then, certainly with the risk, why you manage revenues as money's coming in the door. On the value-based side, you more have a tendency to manage cost. You want to have some sense of control over the cost and the quality and make sure that ensures balance going forward. Next slide. And so when we do talk about that, the redesigned incentives, here we've got, a carrot on a stick, if you will, and that stick is being controlled by a healthier lifestyle. And working with health providers and health systems, we all know that while we're working toward that possibility of being responsible for our patients' health all the time, it is difficult in making inroads and impacts on their life once they leave your immediate face-to-face influence. And so we do look at telehealth and wearables and technology, enabling us to stay in better touch with our patients. I know last time I was in California, there was quite a conversation about non-traditional touches and how can we provide care coordination, what type of providers, what type of services will enable us to show those better outcomes. And so, on a personal note, it wasn't too long ago. Fortunately, I've been fairly healthy lately. And my insurance company is really encouraging me to establish a primary care doctor, get a physical. I talked about grabbing glasses. I'm at that age where, it's time for those checkups and those tests. And so they actually have a financial incentive for me to just go to my doctor. It's in their best interest that I go to the doctor. So they're willing to pay me. And so at this point, finding out where your patients are, how to engage them, and how to keep track of them over time is going to be paramount. Next slide. And this is just an attempt at humor when we talk about the path to payment, that transition, getting folks to look at it. I think we are going to look at a lot of squiggly lines. We're going to make some mistakes privately and probably some mistakes publicly as we go forward and try to navigate this new payment system. Certainly, the game itself hasn't changed, and that most folks want to see financial stability and growth on their own organizations, and that will require some tough negotiations between payers and providers. Even the data elements. What data is available to make decisions, and how do you access other types of data? Pharmacy costs. The list just goes on. And if we stop to just dwell on too much of it, it's a bit overwhelming. But we do have to, and that's part of the AFS process, is finding those scenarios, finding those actions that we can identify and really put our effort toward now as we go forward, just to eliminate the level of surprise. And then here, that's fine, good transition. And here, we talk about some of those metrics that we mentioned earlier. These are the ones that we're going to be keeping an eye on going forward. And again, it's good to have a benchmark and context. Provider productivity becomes more important as we transition to team-based care, not just the physician-driven care. You've got cost per visit and cost per patient. Again, Susan mentioned that we're actually working on that cost of care documentation and process. So hopefully that becomes available through this process. And then looking at medical support staff, if we're allowing our medical support staff to provide more services in lieu of a physician or a mid-level, what do those staffing ratios look like? And certainly the cost for different types of staff are different. So needing to know who's providing what service and how you're being reimbursed for that, and its impact on that patient's health care. Next slide. And then we've got yet another attempt at humor. When we go through all this, communication is utmost importance. I mean, certainly collecting your data and then communicating with your board and your staff and your payers and your patients. I think there's been an appropriate amount as well, tremendous amount of activity and advocacy, knowing our return on investment for our patients across the country as we work with Congress to, ensure ongoing stability financially and its growth. So I think communication, between providers within an organization, between, supporters such as Capital Link and the healthcare providers and decision makers, it's just going to become more important. And certainly a lot of the terms and acronyms that we use, we're going to have to be careful to clarify and define those and to make sure that folks are on the same page. We certainly want to, like the cartoon says, we certainly want to keep the patient on the table. Next slide. And so additional tools and trainings, I think that we're going to transition back to Susan and kind of wrap this part of the presentation.
Thank you, Jonathan. So I just do want to spend a few more minutes talking about what's coming down the pike in addition to some of the programs we've been offering up through the first couple of sessions, as well. We'll continue a lot of those programs and be offering some new ones. And wanted to give you some food for thought and also welcome your input and guidance on what would be most helpful. You'll be getting some solicitations for feedback from Lisa and her team at the Community Clinic Association. One of the things we found particularly helpful this year, if you go to the next slide there, Kaylee, is that we've developed an RCM toolkit. And that's been very popular. We have, this is actually accessible and available, the RCM toolkit, to CCALAC clinic members. It has not been made available to the general public yet, but because of our Advancing Financial Strength program with the LA group, it is available to you folks. So if you're interested in seeing that before a training, let me know. But otherwise, we usually provide that at the same time as RCM training. But again, it's available anyway. And we found that that's been particularly useful and helpful for people. And we presented it initially, this particular toolkit and the training, as more of a strategic overview. So if you go to kind of the second page, the next page there, Kaylee, I can talk to that a little bit. You can see that there's really a whole life cycle of an encounter. And one of the things that goes along with what we were saying in terms of this isn't really a finance function and this isn't really a financial training program. It's more for the whole organization. And one of the things we've really found is how much revenue cycle management is impacted by all of the steps along the way. And that folks that are not kind of revenue cycle managers or billers or collectors have also found how important their particular role is, and that understanding the various aspects and all the steps involved. They're not going to get into the nitty-gritty of how you bill or exactly how that works, but understanding the components of it has been quite helpful to people. So our toolkit includes more information on all of these kind of steps. And so again, I'm happy to share that with you, but we will also be doing some more training, strategic level training. But the other thing we're trying to do, if we move to the next page, the next slide, is look at some benchmarks and best practices for RCM. And there are some kind of industry guidelines and some ideas that it seems a lot of folks aren't as aware of. Certainly the RCM people know that, but in terms of the rest of the staff, sometimes they don't understand how little changes can make a big difference in some of these areas, and what is kind of best practices and what are some guidelines. We've started to provide those as part of the toolkit. I included just a few statistics here. So some of the front end sample metrics for best practices are the schedule occupancy rate of 95%, registration of 98%, insurance verification of 98%. So if you're aware of your own statistics and they're not in that range, it's important to understand why they're not. There could be a very good reason. So numbers are numbers, they're guidelines and benchmarks. But it could, if they're significantly worse than these in some areas, it could indicate an opportunity for improvement. And we have seen some very significant improvement in a few of the health centers, and that's, I'm sure, part of what's driving the big improvement in the cash flow. We know it's also due to the changing payer mix, but certainly there's been some incremental improvement due to the time and attention that's been put to these areas by some of the health centers that have been involved in the Advancing Financial Strength program. So those are some front-end metrics, and there's some back-end metrics on the next page in terms of when claims are billed and how. So basically 95% should be electronically billed, 2 days from to claim submission, and a 5% denial rate of best practices. So again, these are just some of the many statistics we have available. It may be interesting as we go along. We found a lot of good sharing and trust level between the health centers. So if it's helpful to share CCALAC information more specifically, either within AFS or within broader initiatives that you guys are doing as a clinic consortium, that could be great, and we're happy to compare and include that information in some of the analyses that we're doing. But definitely, please come to the RCM training programs and help inform those programs in terms of what you would find most interesting and helpful, and let us know if you'd like to see that toolkit. So lots more to come in that area. Another new area that we started last year and will continue to build upon is a program on reducing no-show rates. We did a 250 training program on that last year, and the participants were a lot of schedulers were certainly there, and some folks from the clinical side as well. And there were probably about 25 people. And we learned a lot and shared a lot in terms of some of the challenges and some of the best practices. And one of the things I love to show, I'm a CFO by trade, so I think it's, but the numbers are very impactful. We talk about financial sustainability, but also increased access. And we know that what we need is more providers and being able to fit more people in. So we think about no-show rates and what a significant impact they have on the business. And so I just put together a couple of little metrics that we shared at the training program last spring. That basically, if you do a 1% reduction in no-shows and you have 10,000 appointments annually, and it's $150 per patient visit, you can do 100 more visits a month, and that's $15,000 over the course of a year. We think, in general, reductions of 1 point in no-show rates are quite doable. We've seen some improvements of 10 points or more. In some of the programs that we've been involved in. We do have a consultant that we work with that has worked directly with the health centers and had some very significant improvement on that. So if you're struggling with no-show rates, which it seems like everybody is, hopefully you will come to some of these programs and share what you've learned and hear from your colleagues as well. And then just another, kind of number, because we've got to have some metrics in here. 15% reduction in no-shows with 20,000 visits per year is an extra 3,000 visits a year. Now, 15-point reduction in no-show is very significant, but we have seen that with at least one health center that we've been working with through a consultant. So it is possible, but usually if it's that big a reduction, you're starting from a pretty high mark. So hopefully you guys, your no-show rates aren't that high. Another new program is going to be the cost of care training and analysis. There's been a much bigger emphasis on this. Capital Link is working with NAC. We're putting out a major new study and study, a report, and a little toolkit that will be coming to all health centers through co-branded with Capital Link and NAC, but which you will all receive information on and be able to get free of charge, of course, through our HRSA cooperative agreement. But what we hope to also do through the association and through the AFS program is to provide individual toolkits, or I guess it's actually just a little tool, more than a toolkit, to look at your own cost of care analysis. We'll be able to produce reports looking at your costs on different medical areas, dental areas, behavioral health, and so forth, broken down by these different UDS categories, and how your costs compare to your peers if we want to do CCALAC cuts, or California, or other items that we might want to compare by. So that's something we're looking to do and hoping to do if that's something of interest to you and to the CCALAC senior leadership team. So lots of new stuff. We're going to continue all of the foundational learning we did last year. We've continue to build upon the program, but also want to continue to deepen and strengthen it. So if you're new to AFS, I encourage you to go to some of the preliminary programs, which we said are really prerequisites for the upper level ones. And that's just because some of the terminology and some of the calculations and so forth, you just, if you don't have kind of that quick basic knowledge, it won't be as useful to attend the other programs. But if you are a returning AFS member, or if you are a CFO and already know metrics and just want to go to more advanced training or whatever, definitely talk to Lisa. Make sure you're going to the most appropriate and helpful programs. And just wrapping up, as we started at the beginning, what does success look like, and how can we help contribute to that? So Capital Link really wants to be available to provide you with the benchmarks and data and information you need for good decision making. Have the time, the info, resources to plan, productive teams. Hopefully the operations become more and more stable and efficient. Patients and staff are happier, outcomes continue to be great, and overall financial sustainability and access to care. So that's our overall goal with the program, to support CCALAC and their initiatives to help you all with you helping your clients and your patients and the folks that you're trying to assist. So we're really excited to be a partner in this program. I don't know if anyone has any specific questions or if Kaylee has any final comments, or Jonathan, but that's really all that I wanted to say. Our contact information is here. please don't hesitate to contact any of us. Tony, many of you might already know, he's actually physically in California. He lives in California. His office is in California. The other three of us, myself, Jonathan, and Cindy, spent a very large amount of time in California, which is great. If you need, if you get to travel, it's a great place to travel. So a lot of time in LA at the program with CCALAC, but also throughout the state. So we will be at all of us at the CPCA annual conference next week. If you're there, please stop by our booth, introduce yourself, because I'd really love to meet you. We'll hopefully see you at a lot of programs in person, but it's always nice to put a face with a name. So that's it for me. Thank you.
Thank you so much, Susan and Jonathan. If anyone has any questions or follow-ups, you can always email Lisa at lfisher@ccalac.org, or you can email me, Kay Cornelson@ccalac.org, and I will be sending out a PDF version of the slides from today. Please be sure to fill out the survey evaluation that should pop up in your GoToWebinar as I close out today, and we look forward to seeing you at our future events. Thank you.